Okay, hi. So I'm unmuted now. My name is Kwok. We're going to talk a little bit about the assessment, and what I would encourage you to do is to go either into the chat box or to scan with a QR code, or to just write in your web browser this link here, and that way you'll be able to access the slides, and that way you can provide some feedback if you will, and if I am talking too quickly, you can always go back to some of the slides there. I'm just going to get started now. I'm going to show the slides, and the link will stay at the top hand corner, and you'll also be able to see my my subtitles at the bottom. So actually I'm going to turn that off, if that's better. Okay, so we're going to talk about functional self-assessments and monitoring among older populations. I'd like to thank everybody for attending this last minute, and I saw you have quite good interaction. The way that this will be run is I'll give some information, we'll watch some videos, and you'll get a chance to discuss towards the end. Let's begin. So just an update. If you're unfamiliar with this, the European Federation of Adaptive Physical Activity is the European organization concerned with promotion and dissemination of experiences, results, and findings in the fields of adaptive physical activity and sports science, and their practical applications to the benefits of individuals across the lifespan. And that's our website, ufapa.eu. There's a chat message saying that the file is missing. It should be on the browser. If you just clicked on the link in the chat box, you're able to open up as a browser. What we do as a federation is that we look after three main things. One is look at the standards of adaptive physical activity. The other is we have a journal of adaptive physical activity, and we hold biennial conferences. So the next one will be held in Coimbra in Portugal in June 9th to 11th, 2022, so next summer, and hopefully we're going to be in a situation where people can travel and people can attend conferences if they can, and in this situation it will be in the summer in Coimbra in Portugal. So hopefully some of you will consider attending this after getting some information about adaptive physical activity, and hopefully you have a bit of interest in this area after what we provide in this course, in these sessions. So the aims of this lecture is that you'll be familiar with the standards, that's the USAPA, and with particular reference to APA. So someone is unmuted. Hello? Can we try to remute someone? Is that possible?
Yes, I'm trying.
Okay, and so with particular reference to the APA in rehabilitation, of course, UFAPA, we also cover physical education, we also cover sports as well. So that's the adaptive physical education, which I'm not going to cover in this lecture, and with sports and leisure, which again is not going to be covered in this lecture. Still hearing this person. Does anybody know how to contact this person to ask them to mute themselves?
We are trying.
Okay, fantastic, good. Okay, and then be informed of evidence-based assessments, or APA, amongst older populations. We've talked a lot about given a lot of information about APA with diabetes and older populations, so there will be some overlap, a little bit about remote assessments, and then we might have a chance to discuss the monitoring methods as well at the end. So let's begin. So here is the outline that we cover. So the European standards is or was designed in 2010 to develop an international academic framework for the professional preparations of adaptive physical activity at the European level. The access doesn't work. 1 second. Just see where we are. Resume session. Okay. I don't know why it's not working. It normally has worked in the past. Maybe we just have to follow with this. Okay, otherwise I'll have to set up a new link. So adaptive physical activities in rehabilitation is, we have this definition of what rehabilitation is, and it is a healthcare professional that provides treatment to individuals to develop, maintain, and/or restore maximal movement and function throughout life. This includes providing treatment in circumstances where movement and function are threatened by aging, injury, diseases, or environmental factors. So of course, in this presentation, we're going to focus particularly with the aging part. So we're looking at the older populations. Of course, rehabilitation has this wide spectrum of people that are going to go from injuries and to have high performance to those people that just look at functioning in an everyday life. Rehabilitation can take place in both in and out of patient settings, and there are operational definitions that are used differently in different countries. So therefore, the standards is one way of looking how APA is used within rehabilitation. So adaptive physical activity is not considered as a separate entity within the multidisciplinary character of rehabilitation. So what do we mean by this? What the issue is that when you look at rehabilitation sciences, the terms adaptive physical activity isn't explicitly written in some of the texts, but actually a lot of the work is adaptive physical activity when you do the rehabilitation. So it's there are overlaps in the pure work of rehabilitation and its purpose. If the main purpose is to get to quality of life, as well as improvement in quality of life, and where adaptive physical activity is on its own. So despite its core practice in rehabilitation, there are no legislatively non-clementure for the inclusion of APA, and legislative professional status is lacking, such that the following needs to work in other roles. So there is the need to work with other people, for example, the actual therapists that are specialized in adaptive physical activity, the specialists that work in terms of rehabilitation and the individuals, as well as the instructors, etc., that guide the sessions and the program management. So what the issue behind this is that if you don't have a legal framework around this, then typically anybody can say, well, I can do this. And there's some potential problems with this, because you might misguide someone to have lower outcomes as a result of the session. And that's one of the reasons why we train people up and we have professional standards in this area. And APA is often considered part of the physiotherapy training, as we've seen in many countries, part of that standards. And so there is a need to have that within the standard on its own. So the benefits of APA in rehabilitation is if the end goal is the improvement quality of life, and it's done under 3 different pillars. There's the integrated rehabilitation training program, there's the individual psychosocial well-being, and there's the self-reflective education and health-related issues. What do we mean by this is that these 3 pillars, when you work with all 3 areas, you're striving to improve the quality of life of the individual. That one pillar on its own is not enough to improve the quality of life. It means that individuals that work in rehabilitation need to be aware of these three different pillars and be able to work at these three areas, at least get the individual to be aware of this as well, particularly the self-reflective education and health-related issues, as mentioned earlier with the health literacy aspects. That's become a more common term used in the last decade or so. Individual psychosocial well-being can be a key driver to behavior change and sustaining active lifestyles, as well as the integrated rehabilitation training program means that it's at the different sectors, as well as working with different people who provide the programs themselves. Under the standards, the key activities of APA in rehabilitation includes the planning, the education, the assessment, and the implementation. When you do the planning, you have to coordinate with others. As mentioned, they could be the therapists, the specialists, the teachers, depending on who you're working with. If you're working with older populations, potentially it's with the people who work with the individuals directly. If they're living in a care setting, there's also them as well. There's the planning of the health risks in terms of what is overly exertion, as mentioned from Aya earlier, and what are some of the risk factors that can happen as a result of doing APA. The education is also needed, where we have to continually provide information about community opportunities and be aware of patient contraindicators. So contraindicators are those that we see signs of exercises to avoid because there are too great risks involved from the benefits of doing the exercise. Then there's the assessment. So there's the assessment of the programs and evaluations to see whether they are working, as well as the individual progress, where you can see at an individual level whether they have made improvements. And we'll cover that in much more detail later. And then, of course, there's the implementation. And implementation is becoming more and more important these days, because we want to check that the program runs as it is intended. That means we have to coordinate it in a way that we want to make sure that we plan for something to happen and it goes as expected. We also have to conduct the sessions, and we have to develop and refine it based on individuals, because everybody has their own differences. That mass implementation cannot really happen in the same way as if we were in a factory, where you have robotics, where when you expect to make a car or anything that's machinery based, you expect there to be about 1% that would be a fault. Like, let's say you're trying to buy a pair of trousers, and you notice that those trousers are slightly shorter than the other trousers. That's a manufacturing fault, but that's expecting that all the trousers would be the same length. Now with humans, they're much more complicated than that, so we have to spend much more time on coordinating the implementation. So what are some of the competencies needed under the standards? There's the therapeutic competencies, the pedagogical competencies, and the management. And there's the curriculum, where you look at the pedagogical aspects, the active lifestyles, and the recreational sports. So under the therapy, look at having the competencies to be able to consider the different conditions that people have. So the last lecture was really good in terms of giving you an understanding of diabetes, trying to understand the functioning and the functional limitations of individuals, as well as therapeutic understanding of safety, of what can be done, where can it be done, and with who can it be done with. Then there's the pedagogical competencies, the need to be able to communicate the exercises for groups, for individuals, to be able to give clear instructions so that people can follow that and be able to do the activities as intended. And then there's also the encouragement. Of course, we can tell people to try to do things, but they have to be motivated. Physical activity is an action that people need to do. It isn't the same as sitting on a couch watching television, where you can be sedentary and you just use the back of your brain and just be kind of brainwashed. in the sense of what happens when we watch television, or as you're in this lecture, you're sitting there or standing and you're just absorbing the information. You don't need to do anything. I don't need to encourage you for this. Okay, but for physical activity, you need to be active. You need to be able to do something. So that requires some encouragement, because some people might find it's too difficult, it's hard work, it's too exertive, and it may not be enjoyable. And that's where the pedagogical competencies come in place there. Then there's the management issues. You need the competencies to work in a multidisciplinary area, especially in rehabilitation, especially in adaptive physical activity, because it's not just one person that does this work. You got to be working with your colleagues and the people working around the individual. There's the need to have competencies in planning the program. You have to have strategic policies to see where things fall in place for the individual, as well as management of understanding the eligibility criteria of people who have access to this, as well as who will benefit from this. So the aims of courses to deliver professionals. So this is at the APA in rehabilitation. Aims of courses to deliver professionals with all
Kwok, we lost you.
All with sufficient competencies, background knowledge, and let's give a little bit of information about the older populations groups. So here, if you are not aware of this, we have an aging population globally. Okay, what you see in this figure here, provided from the United Nations in 2017, is the actual percentage of older populations over the age of 60, percentage-wise of their national population. And what you see in Africa, the red line is at 5% in 1980, and it's still around about 5% in 2017. But if you look at Europe, the one at the top, the blue line, it started off around about 15%, 16%, and now we're almost at 25%. And the projections are even more severe. By 2050, the projection in Europe is around about 35%. That's 1/3 of the population. 1 in 3 people that we encounter in Europe will be aged over the age of 60. Okay. And as we know, with the age of 60, there's a lot of functional decline and also a lot of need to have to work with them. And this is a lot to do with the quality of life that people have had, and the healthcare settings and preventive care, and also promotive activities as well. But now what we've got to do is be able to work with this so then people can continue to have a high quality of life. So one of the things that you must be familiar with is the ICF, the International Classification of Functional Disability in Health. Okay, so I'm going to put a different perspective of how you look at the ICF. So what we know in life, there are 2 main facts. There's 2 very clear facts we know. Everything else is uncertain. One is that a person is born and a person dies. Okay, these are 2 undisputable facts. And what goes in between the birth and the death, the white and the black, is what happens in life. Okay, and there's a lot of uncertainty. And in terms of functioning, there's a gradient change from the whiteness of, well, I wouldn't say that a baby has full functioning, but hopefully you get an idea that the functioning is more optimal at the younger age compared with at the older age, when they almost have no function at all, which leads to death. And this is whereby we can do manipulations with this gray area, with this change. And this, hopefully you may have seen some Chinese oriental symbols of this yin yang, where you've got the black and the white and what goes in between that. So some of the factors to take into consideration for older population is the history of the individual. Okay, you have to think about the person has lived, okay, 50, 60, 70 years of their life, okay, and more on this planet. They've got a wealth of information and knowledge, okay, about what they can do, what they want to do, and how they're going to do that. Okay, and this is the human side of the ICF. the humanly aspect of things is to try and understand that they are humans, and humans are very different. We have different bodily functions and organs from other organisms, but also the way we communicate is quite different from how other organisms communicate with each other. We have a lot of emphasis on being healthy and staying healthy, and that's under the ICF to stay there. There's also the harmony. Okay, so we don't tend to think about this with the ICF, but with the harmony in terms of when you think about where you are positioned in your life with everybody else around you, that's where you look at the environmental factors and the personal factors, and the context, otherwise known as the contextual factors, is the harmony of where you feel that you are with your functioning and how you live your activities and your participations. And it's a very hot topic today. It's hot today. It's a current area of discussion, and it's been going on since the ICF has been around, and it continues to be, particularly as the aged population has become even more so, especially in Europe. And so as a result of this, we have to be smart in the way that we do things. And if you constantly think about what the ICF can do for you, you'll be able to succeed more with your goals in being able to deliver what you want to deliver, particularly with older populations. So here's another statistic, again from the United Nations. And what you see here is that you've got a light blue, you've got a dark blue, and you've got a green, and then you've got a gray at the top. And what this is showing you is that where people are living, okay, for older populations. So again, this is over 60s, and you see the bottom bar, the lighter blue shades are for those who live alone. And you see around about globally, approximately, it's around about 33%. And you see that it changes considerably depending on, well, not so bad, but it changes and probably gets less as you see the data goes to the countries on the right-hand side. The area in the blue, dark blue, are those people who live with their spouses. So that could be their wife, husband, or partner, okay, or someone that they live with majority of their life, and that's their spouse. And then what you can see in the Netherlands is that almost 95%, so this is one on the far left corner, okay, you can see that almost 95% either live on their own or they live with their partner. Okay, the green bar is those that live in care homes. So they live in a housing arrangement that's with with their children. Sorry, they only live with their children, not with their care home. So in other words, that the children are looking after the older people. So they've moved either the children into the house of the older population, or the older population have moved into the house of the children. Okay, and you can see that it increases as we look towards the right. And the ones that are other on the grey are places like care homes and things like that. So where is Ukraine in this? So you'll see Ukraine is the area that I've just highlighted here. And what you see is quite an interesting, almost equal distribution, about a third. And this data was collected in 2007, and there hasn't been any updated data available for this figure between 2007 and 2017. It may have changed in the last 15 years or so. But what you see is that there's about a third that live alone, a third that live with their spouse, and a third with children. Now, this is important in terms of when you deliver physical activity to people, because if they're living on their own, then you have to really consider the risk factors, especially if you're doing things remotely. Because if they have to leave the house, or if they're doing things on their own, if they have an accident, then is there someone there to help them? If you're with their spouse, maybe they can do the activity with the person, or maybe some of the risk factors are mitigated because the one person is exercising and the other person may be nearby, who can then help, might be able to encourage the person, might be able to call for emergency services if something was to happen. And similarly with when they're living with children. And the issue with the children is that probably they are working. So at the times of when they are doing the activities and exercise, it's probably at the time when the children are working. Okay, so we're not talking about children being young children, as in like under 18s, but it's the children of the older people. Okay, and in this situation, they're probably working because the rest of the day, that tends to happen in those circumstances. So that's quite an interesting situation. I think it's very balanced in Ukraine in terms of how it's distributed. And you can see in how this is in other countries as well. So I'm just going to signpost a little bit about Finland, because this is where I do most of my work, and I live in Finland. And this has come from a study from 2017. They had 10,000 people involved in this survey of over 18-year-olds, and about a third of them were over the age of 65. And what you'll see in Finland is that they have the largest percentage of over 60s in the whole of Europe in their country's population. So this is a little bit overrepresentative, because there is approximately 10% of the population with over 60s. But nonetheless, this gives you a good snapshot of this data that they had. And Finland has had this oldest population for almost the last 5 years now. They were either first or second or third, but now they are certainly has the largest, oldest population. And that's one of the things, the reasons for the COVID-19 vaccines has been slow to distribute, because they've been given the older populations first. But in this study, anyway, they collected from 10,000 people their functional performance, their vision, their memory and learning, their weight and height, blood tests, and questionnaires on their health, function, and well-being. And there's a link to the document. It's in Finnish, but at least you can see some of the percentages, or you can maybe Google translate the PDF into your chosen language. I don't know how it works from Finnish to Ukrainian translation, because Finnish to English Google translation is not necessarily brilliant either. But anyway, I'm just showing you a little bit of the findings that have been reported from this study. So first of all, what you see on the left-hand side is the questions about psychological distress. And what you see in the circled areas of the purple is that across the age groups, so you've got the light blue, which is from the 60 to 69-year-olds, the purple, the pink, the one in the middle is 70 to 79, and the purple is the 80-plus-year-olds. And you see the percentage of people that say that they feel lonely is considerably higher in women and men from the younger, older age group. Okay, and then what you see is the second graph is the cognitive abilities of older people. And what you see here is the percentage of people that have their ability to recall 4 or less than from 10 words. So in this test, we give them 10 different words, and we ask them, can they call out as many of those words as possible from those 10? And this is the percentage of them that can only recall 4 or less. So this is a cognitive test, and what you can see considerably that the cognitive abilities is decreases with age, and much more with when they reach over the age of 80. And what you see at the lower end of the bottom left of this presentation, of this slide, is the psychological distress. What you see is on average, there's around about a quarter of women that have reported psychological distress, and there's a big jump when you reach to 80 years and over. And with men, the psychological distress is lower. Okay, and again, there's a big jump when they reach the age 80 and over. On the right-hand side, we're looking at some of the activities that they work in. So if you think about the ICF, you think about their participation and activities. And what we see here is very little difference in terms of the percentage of people doing club activities, a decline in those people going out to theatres, cinemas. Okay, and this is important for daily living. And importantly, the physical activity, there's a percentage older from 60 to 70 to 80.
Kwok, there is some interruption with sound. I'm not sure if it's just for me or for all others. If someone can type in chat room, can you hear Kwok?
No, we don't hear.
Okay, so okay, he was probably kicked out from this meeting, but hopefully he will come back. So just hold on and be patient. Probably there's some internet problems for him. So yeah, we'll try to solve this technical problem. I just talked to Kwok on phone.
So
Yeah, we are trying to get back Kwok in the meeting because there was some internet problem for him, and he sent me a message that he's trying to reconnect. So just, yeah, if you want to stretch out, if you want to get another cup of coffee or want to get some water, so yeah, hopefully in a minute or 2 or 3 minutes, he will be back.
yeah, so I'll move this forwards. Okay, so some of the physical functioning results. Here what we see is the limited squatting, and what they do is the percentage of those who can only go down to a certain squatting level, the percentage of people who can't rise from a chair without using a hand. And you can see that women have more difficulties than with men, and there's an increase with 80-year-olds as well as walking half a kilometer. There's quite a big decline, and climbing up one flight of stairs in the standard test, as well as with running 100 meters. There's quite a big decline, and about 50% of women can run 100 meters and 60% of men age 60 to 69. So some of the things to consider when you're looking at doing physical activity for older populations, there's the risk of falling, and then there's the risk of inactivity. And some of the things that we have to consider is to provide exercises where they reduce the risk of falling. If they are not physically active, then reduce their function, and then they have a greater risk of falling. But on the other hand, if you don't do the exercises, then they become physically inactive, and that reduces their strength, their reactions, and their balance. And it's an ongoing cycle, because if they don't do the activity, then they have greater risks of falling and so on and so on. So we have to break this cycle by increasing the physical activity, reducing the risk of falling, and increase their functioning. And what you see here is a study whereby you can see that the disability line, this grey line of this threshold of independence, this grey shaded area on the right-hand picture, is showing where people have a threshold for independence, which means that they are regarded to have disabilities. They need societal support. They have difficulties in everyday living with regards to activities and participations. And what you can see is this was an intervention study whereby the usual care of a person A and B would, after some rehabilitation, they could bounce out from this disability, this threshold for independence. And if they didn't have this, then afterwards they would stay in this condition of disability. Whereas if you have an early identification phase, then you can intervene already to boost their level of functioning and keep them out of this disability zone, and therefore they remain more independent and have their high quality of life. So what you see on the left-hand side is the proportion of older medical patients who required physical assistance 2 weeks prior to admission, at admission, and at discharge. And what you can see is quite clearly is the need for assistance in these different areas. And after hospital, then the percentage reduce of personal assistance. So it has worked at hospital, but we want to prevent this from happening in the first place. And this is where the role of rehabilitation in the community setting is really important as well, even before rehabilitation to the habilitation phase. And I believe Elaine will be talking a little bit more about that later. So let's have a look at some of the common physical activity assessments for older populations, because if you're looking at this preventive model, you want to be able to assess where people are on the right-hand side. Okay, so again, going back to the standards, one of the key activities is the assessments. And we're looking in this particular lecture about the individual progress. Now, much of this you should be familiar with. So we're going to go through this quite quickly, and then maybe we will be able to keep on time and allow you to have some discussions. So some of the common terms are, for example, this short physical performance battery, which Aya has already shown a little bit about, this time up and go test, this 30-second sit to stand test, this sit to stand test for 5 times or 5 times, a 6-minute walk test, and a functional reach test. So in the chat box, maybe we can do a little bit of interaction. Could you type in the number of assessments that you are familiar with? Okay, so are you familiar with all 6 of them? Or are you only familiar with 1 of them? Are you familiar with 2 of them, 3 of them, 4, 5, or 6? So just type away in your chat box how many assessments. How many physical assessments are you familiar with? Just type away in the chat box and we can see how familiar you are with them. You might not be familiar with any of them. You might be familiar with all of them. Just in the chat box, just type away one of the numbers. Okay, 2 to 3, 3, okay, 5 to, okay. All right, so some of them are familiar, not all of them are by the early responders. Any other? 3 of them, 3, okay, 2.6, interesting, 2.6, or numbers 2 and 6, I suppose. time up and go, and functional reach test. Okay, 3, yeah, 3.5, 3 or 5. Okay, so the question is how many of them, but it's helpful to know which ones you're also familiar with as well. Okay, so let's go forward, and we'll do some demonstrations, and we'll go forward from this. So the short physical performance battery, the SPPB, is based on older people's lower extremity function and mobility. It's a test for their balance, the gait speed, and their strength.
Kwok, we lost you again. We can't hear. If you speak, we can't hear you. So it's really sorry, it seems there.
So we're just going to show this video, and hopefully it's going to work now.
The purpose of this video is to teach you about the Short Physical Performance Battery Test, or SPPB. The SPPB is a validated tool that we can use to assess a patient's level of physical function as well as their future risk for activities of daily living decline. It is a performance-based test and it will take about 10 minutes to administer. Okay, let's begin the evaluation. I'm going to have you standing in a couple different...
Sorry. Okay, what I suggest that we're going to do right now is that there's a few videos. I'm just going to talk through these. You can watch them in your own time, and actually in your groups to discuss, maybe you can talk about them some more or watch them together. So just due to the interest of time. So there's this short physical battery test. Basically, it covers balance, gait speed, and strength. And these are the resources that you can get from there. The timed up and go test, it seems like people are familiar with this. This one is to determine the full risk through sit to stand, gait, and sway. So if the time is over 12 seconds, then the person is at risk of falling. And there are some common cutoffs for indicating the risk of falling by population groups, whether they are community dwelling adults, whether they are older stroke patients, whether they're frail, elderly, so that could be over 80. There could be amputees in lower limbs, Parkinson's disease, hip or vascular disorders. And more resources are available from the Physiopedia website, as well as the CDC chart and the video that's available in this slide. There's also the sit to stand test. So this has been used for older persons' lower extremities for their strength, balance, and risk of falls. So you can see the common area is about fall prevention for older populations. Okay, and the amount of time it takes to do it for 5 seconds is just over 10 seconds, or 11.4 seconds, 12.6 seconds for 70 to 9-year-olds, and 80, it's almost 15 seconds. So this is a very short video.
The 5 times sit to stand test. The test is a valid and useful tool to help you assess an individual's ability to perform transitional movements. The ability to stand from a chair is a vital factor in independent living. The individual sits with arms folded across chest and their backs against the chair.
Okay, so again, you can watch this slightly later as well. Another test is the 30 seconds sit to stand. And in a similar way to the 5 times, this is the number of times, because the 5 times one can have an effect to it. Whereas the 30 seconds is to see the number of times that they can do this. And again, this has an issue as well. And so there's a 5 times test as well as a 10 times test. So 5 times and 10 times. And it's to measure the length, strength, and endurance as well. And again, you can watch the video on this. And then there's the 6-minute walk test, which Aya has mentioned already. It's a sub-maximal exercise test for endurance and aerobic capacity. And it's to walk as far as possible over 6 meters. And here is a website to follow this. And then the final test is this functional reach test, where you have a dynamic balance test to see how far someone can reach before they can fall over. And there's 1 of 4 tests in the balance outcome measure for elderly population, the Boomer test. And these are the interpretations that you need to have, that you have. If they can only reach 25 centimeters, if they can reach 25 centimeters or greater, then they have a low risk of falls. And compared with those people that can only go between 15 to 25, then their risk of falling is 2 times that of normal. If they can only reach 15 centimeters, they're 4 times greater than normal. And if they're unwilling to do this because they're worried about their balance, then they're 8 times greater the risk than normal. Okay, so what I'm wondering is, we don't have time for breakout rooms because it would be quite a long exercise to do. But you have access to these links. If you've gone to access these slides from the link that I gave you, one thing I should note to you is that once this presentation ends, the slides do not become available. So we will make them available after the presentation though. So if you're wanting to look at them today, I would suggest that you take hold of these links while you can. Okay, so some other types of assessments to consider are paper-based assessments. For example, the functioning, we might ask them to provide an assessment of their motor process skills, might have the Canadian Occupational Performance Measure, there's the FSQ, IPN, HUDAS 2.0, and these are all based on survey response. The psychosocial ones are also pen and paper, where people respond to see how they are feeling in the psychosocial domains. EQ5D, the EuroHIS 8, the RAND 36 is a very big one for well used for quality of life. The WHO Quality of Life Brief is also commonly used as well. The Cohen-Mansfield and the 15D Health, 15 Dimension Health. Okay, so the last section that we're going to have to just jump forwards is this remote monitoring for APA, particularly useful for COVID-19, but also to say that after the pandemic has, after the restrictions may be lifted, so we return back to normal, the question is what is normal? And to say that we need to be in physical places at all times used to be a common barrier for us. Whereas now, what we're finding is that we can deliver things remotely. And so we're going to just spend a bit of time talking about this as well. And I'm giving you an example of what has been used in telesports, so telesport and exercise medicine. In the sense that when you need to have a consultation with an athlete, you have to establish the remote consultation. You have to plan this in advance, and you have to think about how you're going to present the way you're going to communicate between the professional and in this case, the athlete or the client. There's also the need to be aware of ethical guidelines and to ensure that you have remote access to the electronic health record in that case. When it comes down to the connection, so now you've established the time, now you've established which platform you're going to use, now you're actually meeting with that person, then you have to perform the remote consultation. And that's where you need to have a condition-specific guide ready for you. So you need to know what is it that you're going to be working with and then afterwards you perform it by, first of all, introducing yourself and whoever else you're having that session with. You do an initial rapid health status assessment, so very quickly, just to make sure that they can perform the task and respond properly. Take a history to see what has happened between the last time they've made communication and the time of the appointment, and then afterwards start doing the examination and the tests, which is the test that we've just shown you with those links there, the assessments. And then after the consultation, this is important to make comprehensive notes in the health records, particularly so because you're doing things remotely. And then afterwards arrange for further investigations and to follow up where necessary. So some of the things to consider for safety is when you're doing these types of designs, you've got to make sure that you follow the training protocols when they're done remotely. You want to be able to make sure that you've got contact details of someone who you can contact if the person is on their own. Again, it goes back to this issue if they live on their own or with their spouse or with their children or in a care home. Okay, you've got to set up the camera so it's visible so you can see the individual, and you've got to see that check whether there's other people present in case something was to happen, and that the only way is for them to hear is from you shouting on your screen, so then people can hear you in other parts of that place. It's good to have a telephone number in case technology fails. So, like we've just experienced here, some technological failure, and there's a way to communicate through telephone and the document of their client history. You also need to have an emergency protocol set up and ready as you do this. So if you're doing some kind of tests, you've got to set up what happens, what do you do, how do you tell the person what they need to do if something happened, if they and I went into some of that details last August, so I encourage you to look at those slides from that point then. So not August, from September, as you can see from this date here. Just going over some of these issues because some people may not be familiar with this. And again, this was presented last time. This is what a typical tele assessment situation could be. So this is something whereby a person has multiple sclerosis and they're doing the physical exercise and they're asked to do some, they've got this set up with regards to, this is the monitor where the person, the rehabilitations professional is giving them, is observing them and giving them instructions as to what they need to be doing. And you need to check with them, like through the Borg scale, like their perceived exertion, or with a pain scale, with regards to the amount of pain that they might be experiencing due to the exercise, as well as any other ways of communicating with them. So just to reiterate again, there's a very good paper about the procedures to do things online, to have a hybrid mode of considering how you run in the future your professional practice, or as you would do, you do the planning, you then do the connection, you do the try to have the introduction. So here's a typical script that we have in English that would be used in Britain. So you may want to look at this from a from your own contextual ways of introducing each other. So you like ask for their name, date of birth, and their medical number, and then where are you now? Is there someone with you? Please introduce them to me. Do you understand what is possible, not possible during this session? And is there anything they want to say or ask before the session? And are they happy to proceed before going forwards? Okay, then you do the initial rapid assessment. So this is what hurts, what is happening. And again, there's the script for you to consider. And then establish what they want from the consultation, from the session. You may have a planned session program for them, but based on the humanistic perspective, they may want to experience something slightly different. And that's where you need the experience to be flexible where you can. And so you then look at their history just to make sure you've got the medical record, and you might want to ask them if you don't have that available to them. And then you do the examination with regards to what they, we're at number 5, the examination where you assess their physical and mental function the best that you can. And this is where the assessment tools become really important, because some of the times these assessments, they can be done themselves. You don't have to be there to see them get up and down from a chair, for them to walk certain meters and to see how far they can reach, if you have the safety procedures set up well enough. Okay, so then what they can do, they may do the tests, and you can take down this information and then decide what they need to do next, whether they need to have certain programs with regards to their rehabilitation, whether they've made progress, whether they've gotten worse. And that way you can save some of your face-to-face time that you may have if you are actually delivering face-to-face. So just reiteration again, that when you want to set up the cameras, you want to set up whereby it's about just less than 2 meters away from the person. So you can see their entire body. And if they're in a wheelchair, also, you can see their entire movement. The position of the camera should also be off the ground, so you see them at the eye level, and that maybe the head room is just about a hand around above them, so you can see their whole environment around them. And when you want them to do the activities, make sure they've got good clothing, that they are in a private area, and that the camera is steady as you do this. So there are some common strength tests that they can do. For example, they can hold things against gravity. So if you're looking at how much weight they can hold, you might ask them if they can bring a stapler with them and see how long they can hold that stapler with their arm in front of them, or a bottle of water with the bottle above their head or to the side, depending what test you have. And so you weight of these without having for them to be in a gym, in a specialized environment. They can do this at home. You would do this by demonstrating, and you would walk through the instructions first, and that you consider safety at all times, and then you ask them to do the test. Maybe for them to do it once or twice, and then report to you back what they have done. Of course, as you're recording or as you're watching, you don't have to record it. You have to ask their permission. That's the ethical guidelines. But you will be able to make the timing. You've got a stopwatch there, or you've got a pen and paper to measure how many times they're doing something. You may use some online tools with an online stopwatch or something or another to help you with getting the results that you're looking for. And here's an example with regards to the starting position for the 5 times sit to stand test. This position in a chair is 1.5, 2 meters away from the chair. You see the person is got a bit of space above them because they're going to sit up and stand. And the important thing is to know whether they've stood correctly all the way up or whether they've sat down completely. So those are the areas whereby you make those assessments. So if you ask them to do it 5 times, but you can say to them, you've not straightened your legs completely, or you've not sat down completely while they're doing it, so then they have to do another repetition. And you want to be able to see this as they set this up. Another example is with the timed up to go test. If you can get them to use a measuring tape to measure the distance from the chair to a cone or a placeholder, it could be anything, it could be a book, something that is low on the ground, something that they won't trip over if they were going to go around it, and also somewhere in a bit of space that they can move freely around there. And again, you can start with a stopwatch and see how many times they do this. Another example was the functional reach test. So what you see here is that they've set up, even though it's not as a wide wall as you see in the video, you can see where they are, and then you ask them to move in a certain distance and how far they reach. First measure, the second measure, and the third measure to see whether they have the high risks of falls. Again, these are the tests, and here you see the observer is at the top here, that you can ask them how they are doing and what they are doing, and then how far they've got to, and then we can make the kind of the results of the assessments. So I was planning that we would have this breakout rooms, not break rooms, excuse my language there, to do this. We are out of time. We will be out of time. So I suppose this will be useful for you to write up a little bit, to just try to figure out one functional test, and then try to practice this. If you can get your own groups, find your own group of students to practice doing this remotely while you're on Zoom, okay, to see how it is like, what is it like to give instructions remotely. Hopefully you've had some experience of this already because we're 1 year into the pandemic. But in terms of assessments, you know, we may concerned that we have to be in the same room as the individual to do the assessments. But what we're trying to say to you is that you don't have to be in the same room, okay? It's particularly during this pandemic. And then you have to think about going forwards. What happens post-pandemic? Are you going to wait for the appointment times, or can you try to do it at the opportune moments? So, you know, you can maybe get through more patients in more patients in less time, and carry out other work as well. The idea was that you would practice this and give feedback and like you do in normal classes, that you're in a safe environment to do this. Okay, just one other thing is that the SPPB guide is that this is what it looks like on an app. So it's not brand new. This is what it already looks like, and it's already pre-pandemic, and people can do this themselves. So we can have the confidence that the patients can have the technologies there, the patients can do this. It's up to us as professionals to be able to include that into our daily practice or our practices of creating those tests in their own environment. And okay, some people say that they may not give you the right test result. It may not be 100% accurate. The question for you is to ask, is it so important if they are 1 degree out, half a second out? The important thing is that they have their own time to consider, and that they've got to start building trust in themselves, the health education themselves, and to understand if they are not doing it correctly, how to check and make sure they do it correctly in future, and that you're there to help them as well, and them to kind of fabricate some type of result that isn't helpful for one or another. The other side of things is that they kind of is that when we're with someone, that they would perform the test more to the true ability compared with when they're on their own. And so the argument is that during the assessments, they may not perform as well as they should do. Okay, and that, therefore it means that they can get higher levels of support needs. And again, you know, you want to ask them, is this really what they want to have in life? If you look at quality of life and independent living, you might want to ask yourself these questions of the appropriateness of us giving them a test in a laboratory setting, like what we heard about with the VO2 max test, with this 6-minute walk test, but also, and the difficulties that compared with everyday living. If this is how they are actually living, then why do we need to intervene with them? Okay, and there's just one more picture of what happens with the outcomes of the score, that the individual can get this and they can share that with the physio, and this improves their knowledge in all kinds of ways possible. It's based on quantifying self and to quantify your own abilities, and there's quite a big movement with regards to that once these apps have been available. Okay, so we've covered all of these areas. In summary, hopefully I've given you some familiarity with the European standards of adaptive physical activity, with particular reference to APA in rehabilitation. Please have a look at them and read those standards as you do your work. It's not just in physiotherapy, it's not just in physical therapy, but it's also within the realms and areas of adaptive physical activity as well. Provided you some knowledge of the evidence-based assessments. So these are not assessments that I think, oh, this would be nice to test, but these are based on evidence, scientific instruments used for APA for older populations. I've given you the opportunity to know the advantages and disadvantages of remote assessments for older populations. I may have talked more about the advantages than disadvantages, but maybe you already have some concerns and skepticism perhaps with the disadvantages. And unfortunately, we didn't get a chance to discuss this, the monitoring methods, but hopefully that will be a task for you to do in the near future. Okay, so question I have for you, your action. Can you build up the competencies in yourself and older people to stay active? And with that, I would like to just remind you of UFAPA and the conference that we have coming up. And I believe that's the end of my presentation. So I'm going to stop the sharing. I will leave the slides available on the app thing for a few more minutes, and then when I stop, they will be no longer available. So when that happens, please give some feedback